Welcome to Sepsis video. In this video, we are going to learn about recognizing sepsis, initial evaluation and management, reassessment and management plan, septic shock, and other therapies. This patient presented with fever of 39 degrees Celsius, cough with sputum production, and shortness of breath. And these are the vital signs. By definition, patient is in sepsis. Patient has fever, tachycardia, hypotension, which is SBP less than 90 or mean arterial pressure less than 70 millimeter of mercury, tachypnea, and documented or suspicion of infection. Other general variables to consider are altered mental status and hyperglycemia with the given values on the screen. Labs of this patient are as follows: high WBC count, high CRP, very high lactate, creatinine went up from baseline of 85 to 140, and low platelet count. Other labs which can be abnormal in sepsis are as follows: this high bilirubin is usually seen in severe sepsis. Some of these labs also represent organ dysfunction, and they are increase of creatinine of 44.2 micromole per liter from baseline or 0.5 milligram per deciliter from baseline. Platelets less than 100,000, INR greater than 1.5, and hyperbilirubinemia of greater than 70. Arterial hypoxemia with PaO2 FiO2 ratio of less than 300 is considered as organ dysfunction, and PaO2 FiO2 ratio of less than 250 without pneumonia and less than 200 with pneumonia is considered as acute lung injury seen in severe sepsis. Acute oliguria, which is urine output less than 0.5 ml per kg per hour for more than 2 hours despite giving IV fluids, indicate organ dysfunction. So evidence or suspected infection with a combination of these signs and abnormal labs indicate sepsis. Now we recognize that our patient has sepsis. What do we do next? Make sure patient's airway is patent and if breathing is alright or not. Give oxygen to patients who are in sepsis. If there is increased work of breathing, patient needs intubation and mechanical ventilation. Next step is assess perfusion status of the patient. Our patient has hypotension, high lactate, acute kidney injury with increased creatinine, indicate that patient has poor end organ perfusion, so patient need IV fluids. Start IV fluids, send labs, blood cultures, and start broad spectrum antibiotics. Which IV fluids are better? Patient should get either Hartmann solution, which is Ringer's lactate, or IV 0.9% normal saline. Normal saline may cause or worsen hyperchloremic acidosis, so if this is a concern, then use Hartmann's solution. How much fluids should be given? Start with 500 ml or 1 liter boluses. At least 30 ml per kg of fluids should be given in first 3 hours from the time of triage of patient in the ED. Next step is, please reassess the patient after each bolus by looking at blood pressure. The goal is to maintain MAP greater than or equal to 65 millimeter of mercury. Look at heart rate, look at urine output, and also check if the patient is volume overloaded. In the event of persistent hypotension, even after initial fluids, you can monitor the patient with either of the following methods in the first 6 hours. Try to maintain MAP greater than or equal to 65 millimeter of mercury. Look at heart rate, capillary refill, skin findings, and also you can look at urine output. If patient has a central line and resources are available, then please look at CVP. Try to maintain it between 8 to 12 millimeter of mercury, and also try to maintain superior vena cava oxygen saturation greater than 70%. You can also use bedside cardiovascular ultrasound. How long the fluid should be continued? If the reassessment shows that patient is still not perfused well, keep giving rapid IV boluses, but please reassess the patient after each bolus for perfusion status and volume overload. On an average, patients might require 2 to 5 liters of fluids within the first 6 hours. So some patients require more and some patients less. If patients' blood pressure improve with fluids, then IV fluids can be reduced or even discontinued in some cases. If patient's blood pressure is not responding to IV fluids, then patients should be started on vasopressors. This should happen within the first 6 hours of the triage of the patient in the ED. This is called septic shock. Vasopressor of first choice is norepinephrine. If additional agent is needed, epinephrine or vasopressin up to 0.03 units per minute can be added. Patients also need vasopressors if patient goes into pulmonary edema without acquiring good perfusion status. Vasopressors should be used in septic shock patients who does not respond to IV fluids with the goal of maintaining MAP greater than or equal to 65 mm of mercury. The level at which MAP should be maintained depends on patient's pre-morbid blood pressure status. MAP may be maintained higher than 65 mm of mercury in a patient who has uncontrolled hypertension. Along with MAP, also please look at urine output, skin perfusion, mental status of the patient, and serum lactate levels while adjusting both fluids and vasopressors. Once patient is diagnosed of sepsis, in first hour of the triage of the patient in emergency department, make sure airway is patent and breathing is okay. Then send labs including cultures and start on IV fluids. Then start on antibiotics. Antimicrobial therapy should be started within the first hour of recognition of sepsis. Broad spectrum antimicrobial therapy, depending on the local prevalence patterns and susceptibility data, should be initiated. In the first 3 hours of the triage of the patient in the emergency department, sepsis patients should receive at least minimum of 30 ml per kg of IV fluids as described previously in this video. They should be given rapidly as IV boluses of 500 ml or 1 liter. Please reassess the patient after each IV bolus as described in this video previously. In the first 6 hours of the triage of the patient in emergency department, patient should be started on vasopressors if BP is not improving after giving adequate amount of IV fluids. And also please recheck lactate during this time. A specific diagnosis of infection should be made and appropriate treatment should be given for source control as soon as possible, preferably within 12 hours if possible. Next is when to use corticosteroids in sepsis. This is a weak recommendation but is helpful. Next is when to use blood transfusion in sepsis. This is a strong recommendation. Unless patient is actively bleeding or having myocardial ischemia. Thank you for watching this video.